Dear colleagues, here's Dr. Katz from Hamburg, Germany, and I would like to present a case of cataract surgery in a PEX pseudoexfoliation eye. You can see the PEX material on the anterior capsule, and we start with pinching the capsule. Actually, if in PEX case we see folds while pinching the capsule, we should avoid it and use a sharp instrument to penetrate the capsule without pulling the weak zonules. The size of the capsulorhexis should be as big as possible to allow free mobilization of the nucleus without pulling the capsule with it. There is really no problem if we do the capsulorhexis through an area of pseudoexfoliation on the anterior capsule. This is not a weaker capsule. The weaker part is the zonules. And another potential problem, which we do not have here, is iris damage with iris that does not dilate. So we try to do as much hydrodelineation and hydrodissection as possible to separate the entity of the nucleus from the capsule. That way we can manipulate the nucleus without exerting force on the capsule itself. We try to rotate the nucleus, it's not always possible, and then we perform chopping, pushing the nucleus equator to the center and never to the periphery, and try to leviate the sectors separately into the anterior chamber where they can be phacoemulsified easily without transferring unnecessary energy downwards to the capsule area. This can be done quite easily in this case. We don't have any problem with the pupil. The surgery is done under drop anesthesia, and with a little bit of flip we can lift the whole epinucleus to the anterior chamber, mainly using vacuum and less phaco. The irrigation aspiration of the cortex is actually more dangerous for the PEX complications than the phacoemulsification itself. We must avoid in any price pulling the anterior capsule with the aspiration handpiece. So we try to use as much water as possible and less aspiration to release the cortex. If we pull a little bit of cortex, we use low vacuum, and only when we are in the center of the capsule, we use full vacuum, of course, with the opening superior. If there are some residual strands of cortex, we don't have to waste too much time and energy. We can first implant the lens that will stabilize the periphery of the capsule, and then easily continue with the aspiration of the last fibers. When we wish to implant the lens, it is safer to implant the lens under viscoelastic, but in this case we implant underwater. The only viscoelastic we see here is from the injector itself, but it can still be done easily. We implant the lens and we let the haptics expand centrifugally. We do not rotate the lens in this case. We do not push on the capsule. We can only push on the center of the optic to allow residual viscoelastic to float forwards. This cataract surgery in PEX syndrome ended successfully. We have to do as large as possible capsulorhexis to separate the nucleus from the surrounding tissues and try to work as much as possible in the center. And we can also use the lens itself to stabilize the peripheral capsule. In the following videos, we will see more complicated cases of PEX syndrome, and I hope to see you again in our channel. Thank you very much.